Welcome to NeuroNights. It's an online workshop series for brain injury survivors, caregivers, advocates, and professionals. I'm Kedar Hiremath. I'm with Ohio State's Chronic Brain Injury Program, and along with our partners at the OSU Wexner Medical Center and Buckeyes Raising Awareness in Neuroscience student group, we provide educational talks from professionals to build awareness of clinical care, new research, as well as survivor stories to build awareness of survivor experiences, challenges, recovery, and continuing needs. So we're a podcast now. We started back in 2020 as a Zoom meeting for survivors to find their peers, to learn about brain injury, to meet our professionals and some of our students as well. And over the last few years, we've held a number of conversations on all things brain injury, as well as things close to brain injury. So experiences with aging or mental health, thinking about challenges in receiving care or even policy. And here we are today talking about occupational medicine. So this is a new topic for us, even though we've been doing it for a while. So I'm excited to get into this with Dr. Pat McKenna.
I'm the lead physician for occupational medicine. So occupational medicine is a field of medicine that has kind of a long history, and it's a broad-based specialty. It really has its roots kind of in the Industrial Revolution. Evolving from the need to treat workplace injuries and illnesses and to focus on prevention, worker well-being, and generally environmental health. The history of occupational medicine goes back really into ancient times, even into ancient Egypt. There's documentation of people taking care of work-related injury and illness. Again, fast forward, into the Industrial Revolution in the 19th century, you saw an increase in public health movements focusing on the poor working and living conditions in factories and in the industrial setting. Today, in modern practice, occupational and environmental medicine physicians address workplace and environmental hazards, both in the occupational setting and in some cases just in the general environment as well. So we focus on clinical care of workplace illness and injury, pre-placement examinations, so making sure that people are well suited to perform the required elements of their job, fitness for duty evaluations, and then generally sort of promoting worker health and resilience. So that's kind of a long-winded answer, kind of giving you a broad brush understanding of what occupational medicine is and where it comes from. It's not a very well-known specialty.
Yeah.
There's only, I think, around 2,000 or so board-certified occupational medicine physicians in the country. So yeah, we are a small specialty. We did get a little bit more notoriety, I suppose, during the COVID pandemic, when people were, more mindful of workplace hazards and the possibility of getting sick at work. And so, it's a combination really of taking care of workplace injury and illness, but also working to prevent injury and illness that can happen as a result of workplace and environmental hazards.
Well, I mean, I'm a public health professional, and I didn't know about this. Yeah. So this is really interesting to kind of learn a little bit about the history. It's been around for a while, and, a lot of really necessary sort of growth in terms of the way that workers faced potential injury or illness on the job. So in modern practice, what kinds of people do you see, and what are their jobs?
Yeah, so I mean, our primary mission at Ohio State here in the past decade or so really has been to focus mostly on taking care of Ohio State employees. And so that really has centered around largely taking care of employees in the OSU Medical Center. So our healthcare workers and people who work for the medical center.
Okay. You're interested in this work.
Yeah.
How did you get here?
Yeah, so my background, as is true with a lot of folks who end up going into occupational medicine, I started out in a different specialty because coming out of medical school, I didn't know that this specialty existed. So I started out actually in orthopedic surgery. Coming out of medical school, that was the path that I wanted to take. I really wanted to be an orthopedic surgeon. So I started down that path. I did my internship and started my second year residency. really, really enjoyed musculoskeletal medicine, really enjoyed being in the operating room, but really did not enjoy the long hours associated with that.
Sure.
So after 2 years of training, I decided to take a step back and reevaluate things. So I left my orthopedic surgery residency, and I was in a fortunate position of having done medical school under a Navy scholarship. So I had the opportunity to go and start serving back some of my time that I owed for that scholarship. So I worked as a general medical officer, a general practitioner with the Navy, with a squadron of ships outside of Jacksonville, Florida. And that's where I discovered the field of preventive and occupational medicine. Really, truly, all military medicine, unless you're a pediatrician or something like that, but all military medicine is really occupational medicine. You're taking care of active duty members of the military, and you're largely focused on addressing their workplace medical concerns. So making sure that any medical concerns that they have are compatible with their ability to continue serving. So that was really where my eyes were opened to the idea of, again, preventive medicine, focusing on wellness and well-being of the workforce. And then I applied for residency and attended residency at Johns Hopkins for preventive medicine, where I got my master's in public health, and completed all the requirements to eventually then become board certified in both public health preventive medicine and occupational and environmental medicine. So then I continued to work. After I completed my residency, I worked. I still had active duty service time, continued to do that work. I worked in an environmental and preventive medicine unit for the Navy, doing a variety of things. So again, getting to really flex those broad occupational and preventive medicine muscles, doing epidemiology work, doing disease outbreak work, taking care of workplace injury and illness, doing pre-placement exams, the whole variety of different things that we do in this field. I was able to do those in the Navy for about 4 years before eventually separating and then moving back to my home here in Columbus, Ohio, and started working in occupational medicine here. So started out working at Ohio Health, where I worked for about 4 years, and then I moved over to Children's Hospital, Nationwide Children's Hospital, where I was the director for employee health there for a couple of years before eventually making my way over here to Ohio State.
Well, we're certainly glad to have you with all that experience. Yeah. I'm just curious because, you worked in the Navy. It's a very different setting than a college or a university or a hospital.
Right.
What kinds of workplace-related injuries did you find in the Navy? What were the jobs, for example, of the folks that were coming in?
Sure. Well, yeah, a whole variety of things. I mean, when I was working with the ship squadron, it was sailors who work on ships, and there's a variety of different jobs that they can have on there, whether it be weapons kind of stuff or bosun mate, which is sort of a jack of all trades that does all kinds of different things. There's electricians and there's, boiler engineers and all sorts of, it's basically an industrial setting. It's like a factory floating in the water or, a large industrial workplace floating in the water. So a lot of very, technical and mechanical types of jobs. And so, I would see injuries related to that. So I would see people, who would hit their heads on stuff in the ships or who would fall down a ladder and injure, extremities or their back or those kind of things. I would also see just general medical issues, people who developed just chronic illnesses, diabetes, hypertension, the usual kind of stuff that you see in primary care. Occasionally see, injuries or illnesses related to, being exposed to some kind of chemical that they were working with, whether it be a skin exposure or a respiratory exposure. So a broad variety of things that really largely weren't probably too much different from what I would see if I were working in just a general industrial setting.
Sure.
So,
but I can imagine you probably saw some brain injuries there.
Sure. Yeah. Yeah. Absolutely. Yeah. Yeah. I definitely had a number of patients when I was working with the ship who had hit their heads. Ships are tight, congested kind of spaces, and so people hit their heads all the time, unprotected. And so I had a number of patients who had long-term mild traumatic brain injury kind of issues.
Okay.
So yeah.
Well, then you go through all this different change in your career. You've moved on from a lot of different kinds of positions and even branches of medicine.
Yeah.
And kind of back to brain injury now.
Right. Well, yeah. I mean, brain injury really has followed me throughout. I mean, even when I was working and doing general epidemiology, it was always in the military. It was always sort of something floating in the background. People were always talking about ways to assess people for mild traumatic brain injury and prevent mild traumatic brain injury from not only discrete injury but also from blasts and from other things that people are exposed to in the military. And then that really did follow me into the civilian world as well, where I mean the nature of the injuries may differ, but I'd say I see just as much or maybe more head injury and brain injury than I did in the military and in my work now.
It's just ever present, right?
It's ever present. It's really present in so many different arenas of life.
Okay, so brain injury might be everywhere, right? And clearly you're focused on people's occupations now. As you got to Ohio State, or maybe even the work that you were doing at Children's Hospital, what were the kinds of jobs there that might bring people to you with brain injury? Or were there trends? Were there, maybe things that you could take away saying, oh, this is a spot or this is a thing?
Yeah, well, so, really, I mean, brain injury and head injury can happen, again, in any type of work environment. I mean, it's less likely, certainly, if you're working in an office environment or something like that, you don't necessarily have a specific hazard that's going to lead to it. But, just in that case, it's more general hazard of, the slips, trips, and falls or things like that.
I lean my chair back too far.
Yeah, right. You fall off your chair, those kind of things happen. Or if you're working in a warehouse, I see people who get injured by, they're picking boxes off a shelf and they accidentally stand up too fast and they hit their head on a metal shelf, or they're packing boxes into the back of a tractor trailer and a stack of boxes falls over and one of them falls on their head. Those kind of things happen. But yeah, you get into more specific hazards when you get into the healthcare environment. All of those general hazards, those exist wherever you are. You have materials that can fall off shelves. You have slips and falls that can happen. You can fall off your chair. All those things can happen just about anywhere, at home or at work or wherever. You get into the healthcare environment, and then you add, this additional kind of discrete risk, which is that of unpredictable patients. And so that's really what I've seen in the healthcare environment. That's really specific not only to healthcare, but any environment where you're working with people who may be predictable or may be unpredictable. So in the healthcare environment, it primarily is in the behavioral health area, whether it be psychiatric illness or neurobehavioral conditions, neurocognitive conditions, elder care. Then you get really into the area of the concern of workplace violence in its many different kind of flavors.
Sure.
So people, essentially healthcare workers who are doing direct patient care, and come in contact with a patient who either purposefully or not purposefully strikes them in the head and causes an injury.
Well, and that's how we met.
Right.
Not because I was your patient and struck you or something like that. But because of your interest in behavioral health workers.
Right.
So, I just kind of want to think about the storyline of how you came to discover what was going on with behavioral health workers that were at Nationwide Children's Hospital.
Right.
And how that kind of led to some of the research work that you're doing now. So you're in your office, ostensibly, and some of these workers are coming in. So what were those first kind of occurrences like?
Yeah, I mean, so I got to think back a few years, but I mean, this goes back to before when I was working at Nationwide Children's, when I was working with Ohio Health, and I was seeing patients, and they were mostly coming from Children's Hospital, and they would come to me, and yeah, it was surprising. I think, I think the first one that I saw, I was like, oh, okay, I could see how that could happen. This person works with pediatric behavioral health patients, and in this case, this. At the time, I think I was thinking, oh, this person was in the wrong place at the wrong time, or this is kind of a freak incident.
A little bit of a fluke, yeah. Okay.
This person, they got struck by a patient. Okay, this happened, but then I saw it again, and I saw it again, and I noticed that I just started to notice a bit of a trend, and this again goes back probably 6-7 years ago. So when the opportunity arose for me to apply for the job at Nationwide Children's Hospital, I already knew that on the surface level that I'd already noticed a trend there.
Mm-hmm.
But I don't think I really fully grasped the full nature or the full scope of the problem. But then when I interviewed for the job, and when I began the job at Nationwide Children's Hospital, I started to recognize in that leadership really saw it as a problem, and leadership was recognizing it as something that needed to be addressed, and I was being tasked with trying to address it, not only from the aspect of treating these people when they were injured, but trying to do something to prevent it from happening. Given that my background is in public health and preventive medicine, I said, well, yeah, that's what we need to do here. We need to prevent this from happening in the first place, because when head injury happens, when brain injury happens, the results can be unpredictable. We don't know who is going to recover fully and who's not, and oftentimes when people have a brain injury, they don't fully recover, and so yeah, when you've got an injury or illness where it's unpredictable as to whether or not somebody's going to fully recover, we're all much better off just preventing that from happening in the first place.
Well, sure. I mean, that is one of the biggest challenges in brain injury, is really just understanding what's going to happen now. And it's as unique as the individual, right?
Right.
So okay, so you were brought in at one point in your career then for, leadership to say, hey, we have noticed this trend as well. And so what kinds of things were they concerned with in terms of the health of their workers? Obviously their health and well-being, but was it leading to a lot of time off of the job? Was it leading to inability to do the job?
Yeah. So yeah, it's a combination of all of the above, right? So I mean, it's the concern for the well-being of the people that work for you, primarily, I think, and then yeah, it's all of those things as well. It's the lost time. It's the general cost of the medical care. It's the increase in turnover for people, leaving the job because they're worried about either they've been injured or they're afraid of being injured. All of those kind of things come into play from the leadership and the employer standpoint. Just the costs to the employer and to society can become very large very quickly.
Well, and as we think about behavioral health, it's so important. Always has been, but even more light on it now.
Right, and yeah, and you're talking about when you talk about behavioral health, you're talking about an area that has a hard time finding enough people to do the work.
Yeah,
I mean they're critically understaffed at baseline, right? So they have a hard time finding enough staff to provide the services that they need to provide just in general, and then you add this other element, and
it's already a tough
harder,
job,
right?
And hard to maintain folks. And then here's this other piece of it that now we know more about it,
right?
Okay, so now we know more about it. You're seeing them in your clinic. Maybe we should just take a moment to kind of describe what is a behavioral health worker. What kinds of backgrounds do they have, and why is this exposure? Or how does this exposure to brain injury really occur in their day-to-day job?
So yeah, behavioral health workers, their background, they're largely young, in their early 20s. As far as what I've seen, they've got some kind of background in psychology, whether they have an undergrad in psychology or at least a strong interest. I don't know if there's a requirement for a bachelor's degree to go into that work or not, but yeah. So they are essentially the medical assistants or the nurse assistants in the behavioral health wing of a hospital who provide the majority of the direct day-to-day patient care for the inpatients in a behavioral health hospital wing. So if you think about any hospital, you've got your patient care assistants who are the ones who are going in and checking on the patient on a regular basis, making sure that they have everything that they need, making sure that their call button is in reach, making sure that they, have their blood drawn when they need to have it drawn, making sure that they're comfortable. The people who, if you've ever been in the hospital, this is the person that you see most of the time coming in and kind of checking on you, doing your vital signs, all that sort of thing, giving you your medicines. It's usually not the nurses who do that. The nurses, do the less frequent checks and kind of manage those people. So that's really the frontline behavioral health care worker that is really having the most face-to-face interaction.
It's pretty essential to making the whole thing work.
Absolutely. Right. Yeah.
If a patient has a behavioral challenge, these are the workers that also have to react to that. Typically, yeah.
And so, I mean, usually if from what I've seen and what I've from talking to the people who do this work, there are events where, when a patient does kind of become completely dysregulated, say, and starts to lash out or have difficulties controlling their body, whether it be because they're trying to escape or because, they're just completely dysregulated and they don't know what to do, whatever the case may be, oftentimes those are sort of all hands on deck events, right? And so, again, it is primarily this frontline behavioral health worker, but then it's also the nurses or whoever is nearby are usually going to kind of rush in to try and manage the situation, and whether it be de-escalating the person verbally or physically restraining them or whatever the case may be.
And it's not so much that this is a fight they can't win or something like that. It's that there are a lot of regulations on how you need to approach a given patient.
Right.
And restrain does not mean just throw anything at them, right?
Right. Yeah. And I think even if you're in a prison, you've got to use particular strategies and techniques. And even more so in a hospital, and even more so in a pediatric behavioral health hospital,
right?
There's a lot of scrutiny over making sure that you're not doing anything that's going to harm the patient.
Right.
That's the last thing that any of these people want to do is bring any additional harm to the person. So there's certainly a lot of caution that's exercised.
Sure.
And in the pediatric world, there also seems to be, again, I'm not a pediatric behavioral health specialist or psychiatrist, but as I understand it, there tends to be a lot less usage of quote unquote chemical restraints. So in the adult behavioral health world, I think there's a little bit more likelihood of using medications, sedating medications to restrain people who maybe are aggressive or dysregulated. They tend to do that less in the pediatric world for good reason. I mean, I think you just don't want to throw a bunch of medications at a child.
Sure.
When you don't know exactly how they're going to respond to those.
Well, all around, this is a pickle of a situation.
Yeah,
right.
It's a very very challenging situation. And again, it's a situation that I didn't know anything about this 8 years ago. And I think probably 95% of the people in the population have no idea that this is even a problem, right?
Right.
And so, I think part of my goal is to bring more awareness to this, and it's hard because it's a sad story. It's not a story that people want to hear. It's not a story it's not a story I really want to tell, but I think it needs to be told.
Well, now we know it, and so it is important to kind of get it out there. So, okay, so we've got this pickle of a situation. You've got yourself with, your experiences, starting to recognize, hey, here's a trend in this at least this type of worker. You've got leadership around you that's also saying, hey, we've got, our employees at risk, and also, there are operations that we have to continue, and those are challenged as well. So there's a lot of different perspectives, but everybody trying to solve the problem.
Working at Nationwide Children's Hospital, I decided, I need to go and visit this work environment and take a look at how it's laid out, what things look like. There's a lot of information can be gleaned just by going and visiting a workplace. That's one of the things that we do in occupational medicine. We do work site surveys, where we go out and just look at the environment. And so I arranged a tour with one of the managers there, and she graciously showed me around. And I noticed a few things on that tour. One, when I looked at the bulletin board where they had all the staff names and photos posted, I noticed that they were all very young. And so I had that discussion with the manager at that time, and she acknowledged, part of our problem is we have a very young staff.
Mm-hmm.
They're very passionate about what they do, and they're very well educated, but in a lot of cases lack that practical experience and necessarily knowing how to protect themselves, knowing how to de-escalate situations effectively, knowing how to take defensive sort of postures when they're engaging with patients who might be aggressive. A lot of the learning is really hands-on, and in some cases experience is really the best teacher and the only teacher that can kind of show you how to do that
Sure.
well to protect yourself and avoid injury for yourself. So that was one of the first things I noticed was just the overall youth of the staff. The second big takeaway that I had was when we looked, they have a whole sort of closet dedicated to personal protective equipment, again, for when they are having to deal with these physically aggressive patients. So they've got everything from, padded jackets, padded sort of shields, gloves, things made of Kevlar to prevent being bitten and scratched, face shields, and then they had protective headgear. And what I noticed about the protective headgear is that they're basically martial arts helmets. That's actually what they purchase as protective headgear are martial arts helmets.
It's got the padding.
Yeah.
It's basically just pads, right?
It's basically just padding to go around the head. So just what you would see a boxer wear, or somebody who's doing some kind of martial arts training, doing sparring. Basically just padding that surrounds the face and head. Those are pretty good at preventing people from getting black eyes or soft tissue injuries to their head, but they're actually not good at all at preventing concussion. And if you actually read the label on most of them, they actually say right on it that this is not meant to prevent concussion. This equipment does not effectively prevent concussion or something along those lines.
So you got the superficial kind of taken care of,
Right.
but those deeper things,
Right.
brain rattling around,
Right.
Those kinds of where we see the concussion really is,
Right.
all the
Right.
bouncing around, right? So
So probably doing an okay job of preventing these people from getting soft tissue injuries, but not really doing anything to prevent concussions, which is really the injury that we're the most concerned about.
Sure.
I mean, sure, we want to prevent soft tissue injuries, but I think most of us are much more concerned about preventing concussions than we are about preventing a black eye.
well, in many cases, right, we have a pretty standard procedure for dealing with scrapes and bruises and even broken bones.
Right.
What kinds? I mean, with the brain, obviously, like we've said, unpredictable and could be persistent.
Right.
In terms of the symptoms. What kinds of symptoms were you seeing in these workers?
So after a head injury, the typical concussion symptoms. So directly after an injury, headache, dizziness, maybe some vision changes, whether it be blurry vision, double vision, nausea, in some cases vomiting. So your typical kind of post-concussion injury symptoms, and so those are the symptoms that they would report directly after the injury, and then again in a lot of cases those would then persist. So persistent dizziness, persistent headaches that just won't go away, persistent difficulties with vision, visual tracking issues. Difficulty with balance, all the really kind of typical concussion symptoms are really what I was seeing. And
so pretty straightforward in terms of what we might expect from a person who's had one of those milder, maybe even moderate brain injuries.
Right.
And
I wasn't really seeing anything. I don't I've only seen out of the dozens and dozens of head injuries that I've seen, not only in healthcare but in other occupations as well. I've very rarely seen anything beyond sort of a mild to moderate concussion. So very rarely do I see somebody who's actually lost consciousness or had imaging confirmed, brain bleed or anything like that.
Okay. In this case, we're really thinking about potential repetitive injury.
Right.
If you're
and I started to see the patterns of that as well. I mean, I would see, there were some people that were sort of repeat customers. I have a couple of patients who, have sustained 2, 3, 4 head injuries in under a year.
Wow.
Yeah. So that starts to get, even more concerning. And when you start to think about, things like CTE and the research that I've seen, 2 or 3 head injuries does not necessarily make for chronic traumatic encephalopathy. Sure. But it's certainly especially with it being in the media and something that's, there've been films about it and people are aware of it. And so whether there's an actual true risk of it or not, it's something people are worried about.
Yeah. I can imagine you're getting those questions. Yeah. So you've seen the environment. We kind of have a good sense of what the workers are dealing with on the job. Their symptoms if they do incur a brain injury or exposure to it. So now what? What do we do?
Right. Yeah. So again, we engaged in multidisciplinary discussions. So Nationwide Children's Hospital really is blessed with really good leadership, and they've got a full committee of people who are working diligently to address employee safety issues. So that's where I started. So we started discussing ways to address this. It really does take a multifactorial approach, and that's what we embarked on. So part of it is certainly enhanced training. So making sure that the inexperienced staff has the skills that they need to, engage properly with aggressive patients, to verbally de-escalate, and to use tried and true techniques when they need to physically restrain somebody. Mm-hmm. So making sure that the staff has the skills and the knowledge that they need to protect themselves and protect the patients. So that's always a central component of all of this. Making sure that the treatment pathway was there and that when an injury does occur, that it's recognized early and that the person is that treatment is made available and that they're directed down a treatment pathway to make sure that the appropriate diagnostic workup happens and that they are provided with the treatment that they need.
So is it, in some ways like someone else saw them get a potential head injury and now that's part of their case or that's part of some referral plan? Or are they also thinking about the signs and symptoms that they should be watching out for in themselves? Yeah,
so it's all of that. It's people, recognizing it in each other, recognizing it for their coworkers, educating staff on what to watch out for, both for others and for themselves.
Okay. So pretty comprehensive.
Yeah, and improving the injury reporting system. So making sure that people are reporting when they have an incident, and making sure that reporting system is accessible and that people know how to use it and that they actually do use it, because that can become a problem as well. Yeah. I mean,
do you feel like that wasn't happening, or?
No, I mean, I feel like it was happening, but you don't know. You don't know what you don't know. I mean, if people aren't reporting it, then you don't know that they're not reporting it necessarily. So that's always a concern, I think, in any of these types of things, be it head injury or chemical exposure, or whatever the case may be. There's always the concern of underreporting. Yeah. We always I think we always have to kind of assume that we're not getting the full picture.
Right. I think that's true for concussion writ large, right? We always think that we're missing up to 50% of the cases, which is a wild statistic.
It's just as true, maybe more true in the sports world and places like that where they don't want to report it because they don't want to be taken off the playing field.
But I could see that in a job as well, right?
Yeah, you can have the same thing happen in a job, yeah.
How do you think you prevent this beyond just the education and the awareness, which is critical?
Right.
You got to know what to do, right? As you said, you got to report it.
Right.
What else?
So treatment, prevention from the standpoint of de-escalation and good skills. But then the other sort of elephant in the room that we recognized was the inadequate PPE. So improving upon the PPE to make sure that what we're using actually has the intended effect and actually prevents the injuries that we're trying to prevent. So that's the work that we've embarked on here over the past couple of years since I've been here at Ohio State. And it started while I was at Children's, actually. Even before I moved over to Ohio State, we started on this project of identifying that need for improved PPE. I got in contact with the Injury Biomechanics Research Center here at Ohio State. So I got in touch with them and started working with Julie Mansfield over there. And so the first thing that we did is we took the helmets that were being used, the martial arts helmets, and we compared that with several other off-the-shelf helmets. So we looked at bicycle helmets, and we looked at like a police riot headgear helmet. Mm-hmm. All told, there were 6 or 7 helmets that we looked at. And what the Injury Biomechanics Research Center is able to do is they can actually do sort of crash test dummy work, right? Mm-hmm. So they put these helmets on a crash test dummy head mounted to a sled. So the crash test dummy head, of course, has all kinds of sensors in it to measure the forces, rotational forces, and direct forces. So we put these helmets on this crash test dummy head and impacted it with a piston, with a controlled piston force over and over again, and tested what the force dampening effects were of these different helmets. Yeah. And it confirmed our suspicion that yes, in fact, the martial arts helmet really didn't do anything to reduce the forces that we're concerned about for causing concussion. In fact, they were perhaps even less protective than wearing nothing at all.
Oh,
which was interesting.
Okay, that's a really interesting part of that.
Which we weren't. It was a little puzzling, and I don't know how much you could truly make of it, but the hypothesis there is that it may, just by adding mass to the head, might actually increase the forces, the rotational forces on the brain.
So we have an opportunity to fix it pretty quickly by saying, don't wear them, but you still want some protection, right?
But you still want some protection, and it is, like we said, it is still probably protecting against some of those soft tissue injuries. So, but yeah, again, not doing anything for concussion. So, of all the helmets that we tested, there were some helmets that did provide at least better protection against concussion. And the caveat here is there's no protective headgear that's going to completely prevent people from concussion if they're struck in the head.
Yeah,
football helmets don't do it. Hockey helmets don't do it. They reduce the risk.
Yeah.
And that's what we found is so hockey helmets, some of the bicycle helmets, the riot headgear, the other helmets actually did provide some protective effect. And so then it was a matter of, all right, which, if any of these, might potentially be a suitable replacement. So then we did sort of a pilot project. It was around that time that I was transitioning from Children's over to Ohio State. So then it was a happenstance kind of a thing where I was walking through the James, and the College of Nursing Innovation Studio had just a temporary setup. They were basically
they do a bunch of pop-ups.
Yeah, they had a pop-up where they were kind of just demonstrating what their capabilities were, and I walked by it one day, and I poked my head in, and I saw that they had all this cool equipment. They had laser cutters and 3D printers and all different kinds of stuff, and I said, I've got this and I started talking to them, and they say, oh yeah, we address small scale healthcare problems with sort of innovative solutions. I said, oh, I've got a problem. And so, I started talking to them. I said, do you think that there'd be any interest in this? They're like, well, yeah, that sounds like something that'd be right up our alley.
Yeah.
And so they were great. I mean, they recognized pretty early on, we started talking about it and we had a number of discussions and we recognized fairly early on that this is probably a problem that goes beyond the capabilities of what they can do. In the innovation studio, but they wanted to continue to work on it. They just didn't have everything that they needed to really fully address it.
Yeah, so you needed a bigger scope.
So we needed a bigger scope, and so that's where they suggested. And I think, gosh, I'm trying to remember if they connected me with you. There were so many different pieces that got connected.
We somehow found each other.
It all got connected very quickly, and I don't remember how all the connections happened, but it really did feel like a magical kind of a thing where
stars aligning.
All of a sudden, the stars aligned,
yeah. Right.
and I got connected to you, and I got connected to Jackie Cassis, and everybody at this point, everybody I talked to said, "Yeah, I'm in," and it was a really, really cool experience to all of a sudden have, to not feel so alone in addressing this problem and to have all these other people who were really aligning with the vision of this is a problem that we can address.
Yeah.
So through the Innovation Studio, got connected with you in the chronic brain injury program, got connected with Jackie, and then also got connected through that to the Center for Design and Manufacturing Excellence, M4, which really has the engineering and design expertise to really move this project forward.
It's a big effort. I mean, it's a lot of different kinds of people.
Yeah. So pulled together this team again. To me, after having dealt with this problem for years, and kind of reached what I thought was a dead end.
Yeah.
And then to have this team just kind of assemble, it was like bringing together the Avengers,
Well, it's nice. I mean, the persistence, right? To really see the problem and kind of keep driving towards, I got to help here. I got to do something here, right?
Right.
So you get all the team together, and now you've got this big grant from the Bureau of Workers' Compensation.
Right. Yeah. So with this team, so again, I have this expertise of people who have not only have the design and engineering expertise to do the work, but who have done this kind of thing before, and who have and who know how to access grant funding and things like that, which is that's just not something I've ever really done. I've never really done grant proposals or things like that. And so to have that expertise and have people who know how to access funding like that was huge.
Yeah.
And so we were able to put together, a great proposal to the Bureau of Workers' Compensation and got awarded this $1.5 million grant to move this forward.
And so, I mean, it's still early days on the grant, but I mean, what are you learning so far?
Yeah. So we started in earnest. We grant funding went live beginning of July of this year, and so we started with we'd already done some focus group kind of work, but we kind of did that in a little bit more earnest. Kind of went back to focus groups both at Nationwide Children's as well as down at Cincinnati Children's and at Buckeye Ranch.
Okay.
So we kind of collected more qualitative data from the who will ultimately be sort of the end users of a product that we develop. So that was what most of the initial work involved, to kind of really provide us with again more information about what's lacking about the current protective gear, and provide information on what's needed. What the design constraints are for if we're going to develop a de novo product, what does that de novo product need to be?
Yeah.
What are the minimum standards that we need to achieve with this product? So we got some really interesting information out of that. I mean, we ended up, I think our focus groups, we had 33 people that we ended up talking to in total. 31 out of 33 had either witnessed or experienced a head injury at work.
Wow.
So, that highlights.
It's there.
Yeah. We knew the trend was there, but
now we proved it.
Now we've proved that.
Yeah.
It's borne out in terms of what they're actually experiencing. And then in addition to providing that information and kind of proving that we had a problem, They also then provided a lot of information on what they need they'd need that helmet to look like.
Yeah. Okay. And so then those are the kind of the next steps here.
Yeah.
Is design that.
So now we've taken, this huge list of different sort of design requirements back to our engineering team, and they are diligently working through, looking at different materials and looking at how to make this come together. So
awesome.
So they are now in the process of doing that, and we're looking at now having probably at least a 3D printed sort of prototype, hopefully by January or February of 2026.
Well, maybe we'll have to have you back out during our live follow-up and ask you a little bit more about that part of the process.
Yeah.
We've learned a little bit about occupational medicine and how you're using it in this case to help out a whole class of worker and really do that preventative work. But lots of people have different kinds of jobs, and there's a lot of different environments in which occupational medicine presents itself. And so just curious, we call this a little bit green flags, red flags. So, what are green flags, red flags? If someone is exposed to brain injury in their job, in particular, how do they identify quality care, resources, or maybe even advocate for themselves?
Right. Yeah. So, if you're injured any injury on the job, you need to be aware of what the process is for your employer to report that injury. So make sure that you're reporting it to the appropriate people. So talk to your human resources people, talk to your management, make sure that you're reporting it through the proper channels, and then certainly seek out medical care when you think you need it. So the first place to start certainly can be an urgent care or an emergency department if it warrants that. If it is an urgent or emergent kind of an issue. Be aware that when an injury happens at work, most family medicine doctors don't take care of work-related injuries. They don't engage with the workers' compensation system.
Oh, okay.
So you will likely need to ultimately have care with a workers' compensation physician. There are a number of places to find that. You can go to the Bureau of Workers' Compensation website to connect. That they can connect you to certified providers. Certainly, The Ohio State University, we have our small occupational medicine clinic, and we provide injury care for people across the board. There are a number of other occupational medicine specialists and clinics in Central Ohio.
So you got to get to the right kind of person.
Eventually you need to get to the right kind of person. If you don't know who that is, initially an urgent care is probably a good place to start, and most urgent cares know how to connect you to the right provider.
But you got to just make sure you're telling them this happened on the job.
Right.
Okay. How about, so we also talk about messages that you might have. So what might you tell a survivor of a brain injury who's had it on the job? Maybe things to expect, or ways that they can promote their recovery and getting back to work.
Right. Yeah. So largely, one of the most important things in mild traumatic brain injury treatment these days is really getting back to some level of activity is really important. That's kind of what we've found. So the old days of staying locked in a dark room are no longer valid. That's no longer a valid recommendation. To recover from a mild traumatic brain injury, you really do need to get out there and interact with the world. That's what your brain needs. Your brain needs sensory input, and so you need to get out there and give it what it needs to recover. In some cases, you need more than that as well, but that's something that you're definitely going to need at some point. Is you're going to need to give your brain that sensory input that it needs to recover.
And you recover, and you also talk to the folks that you work with about returning to work and things like that as well.
Yeah, right? And so when you need more than that, again, engaging with a skilled physician or practitioner who can can connect you with additional treatment modalities, whether that be physical therapy, vestibular therapy, there's vision therapy, occupational therapy. There's all these sorts of therapeutic interventions that we can do that can help with recovery when you're not recovering on your own. And again, a skilled occupational medicine provider or or workers' compensation provider will know how to also help you communicate with your employer about whether or not you need to have any kind of work limitations or restrictions or time off work or those kinds of things.
Okay. All right. Well, I think that's our time. So thank you so much.
Yeah, it's been a real pleasure and an honor to be in this inaugural recording.
Yeah, it's been fun. So we'll look forward to learning more about your study and have you back so we can find out what all you accomplished.
I'm looking forward to it too.
All right. Thanks, Dr. McKenna.
Awesome. All right. Thanks, Kedar.